Hello friends, good morning again. Yet another case of total laparoscopic hysterectomy. That's a very bulky uterus you can see, but it's a very special case. The lady is 41-year-old with symptoms of discharge PV and heaviness and mass in the lower abdominal region, especially inside the vaginal region. I'm trying to put a vaginal manipulator inside, you'll know later why it's only trying to, and then the case is being done under spinal anesthesia. Ipsilateral ports are being used. It's a 3-port total laparoscopic hysterectomy, and the patient is 15 degrees head down. Later on we had to put in an eye gel in this patient as she was not tolerating that spinal anesthesia that well, so a GH in backup is very important. And that's how the uterus was. There is a heterogeneous mass measuring around 8.9 into 4 into 5 centimeter arising from the anterior uterine wall into the uterine cavity, projecting into the vagina through the cervix, an endocervical polyp or a pedunculated submucosal fibroid. That's the most important part. So what was it? It's a 9.9 into 5 centimeter oblong fibroid passing through the cervix into the upper vagina. Now that's a challenge, an interesting one. How did we go about operating this lady? We did a TLH with bilateral salpingectomy. The surgery that I am showing is under 2x speed, and she was on mifepristone, progesterones, for maybe more than 6 months or so, and God only knows why she was on mifepristone for that longer period. Maybe they were trying to shrink the fibroid to do probably a hysteroscopic polypectomy, and I don't know how that would have been possible. And the base of this fibroid was around more than 5 to 6 centimeter. So the surgery proceeds in the usual way. I put in a uterine manipulator from below that luckily passed around the fibroid, projecting into the cervix and vagina, and it slipped past. You will see in the later aspect of the surgery. Regular bipolar usage on the left side going into the adnexa, and there's actually nothing great in doing a total laparoscopic hysterectomy. Only the judicious use of these electrosurgical devices and a bit of maneuvering of the wrists. That's all. And ipsilateral port, as I always say, eases the tension on your shoulders. You should not be lurching on the other side of the patient to take on with the right side port. So now separating the bladder, that's the uterine manipulator, Marvaz manipulator cup that I am feeling, which somehow we introduced from below, and left side dissection has been done, and now going for the right side. We have to save the ovaries in this case on the both sides. A bit of smoke that is coming out, that's there with the bipolar shearer, though the speed of dissection is very fast, almost double than that of a harmonic scalpel. A harmonic scalpel is again a very good instrument, should be used especially if you are a beginner, and once you are good at handling instruments and the energy devices, a shearer is always faster and better, what I feel. Only the thing is, the burst of current should be only very short burst. If you give a longer burst of energy, then the chances of formation of VVF is always there, as the thermal injury presents after around 2 to 3 weeks. And for that also we have a trick: put in the omentum over the incision line. That will avoid the VVF formation. So there, approaching the right side uterine artery with the ports on the left side is very easy. You really don't need a right side working port for that. The dissection is almost done. I've taken the uterines from both sides. I'll be speeding up the surgery a bit, as the important part is not the TLH. Important part is how this large fibroid has passed through the cervix, entered the upper vagina, and that has caused a bit of problem. So there the dissection continues. I have separated the bladder, and the cervical fibroid, or you can say the fibroid itself, is working as a bougie on which I am cutting. So if you want to learn this art of laparoscopic surgery, Please do join us as an observer. I do a freelancing surgeries in lots of centers in and around Chandigarh. Please feel free to converse with me on the YouTube or on my Instagram channel, and you can even WhatsApp me. If you really want to learn, obviously, please send me your resume. I'll let you know how and when to contact me and how to go ahead with the observation. As a good observer will always become a good laparoscopic surgeon, because all of the surgery takes place on the screen only. That's why a good observer is required. That's the Foley's bulb. We keep around 5 ml of distilled water in the Foley's, not more than that, else 10 ml. Generally the sister tends to put 10 ml of distilled water or saline in the Foley's. That will make the bladder bulky, so put in minimal amount of normal saline or distilled water in the Foley's. They are dissecting the bladder away. The yellow fat belongs to the bladder, so I am very far away from the bladder, and very short burst of currents. A BVF will never ever form if you use short burst of current. If you are not comfortable with bipolar shearer, and if the bipolar shearer is taking some time in cutting, do go ahead and use a ultrasonic scalpel. Else you can even use cold scissors for this dissection. Earlier, 5-7 years back, we used to cut these tissues with monopolar current. That's a very bad current, as we had no idea what damages it could have done, as the current travels through the bladder towards the electrodes, and that will cause heating and later causing bladder injuries in the past. Though a small VVF gets cured with patient started on, if the patient is started on T-Rol 2 mg twice daily, and keep the Foley's for around 21 to 25 days. So going posteriorly, that's the bulky thing that you can see. That's the fibroid that is projecting into the cervix. In this case, we'll be expecting a very wide cervix, as because of this fibroid. The technique has to be altered a bit. Can't do a regular total laparoscopic hysterectomy, as the cup will not be visible over here. So going by the widths and what we call in Hindi अंदाज़ा लगाते हुए, we carry forward the surgery. As I am already taking the uterine, so now the only formalities are remaining, only the औपचारिकताएं बाकी हैं. There I am cutting on the fibroid. Now I am using the fibroid inside the cervix as a marker for cutting, or you can say I am doing a colpotomy on the fibroid only. So what I feel is that every gynecologist and surgeon should learn total laparoscopic hysterectomy, and please do it under general anesthesia, as in a moving patient surgery is quite a bit difficult. The pressure, intra-abdominal pressure, should not be more than 10 or 12. Your anesthetist will be very comfortable with it. So the dissection continues step by step. You should observe here that the energy burst is in a minimal. If you are using energy for a long time, you can even use a normal saline wash, as the normal saline wash will cool down the tissues a bit, and that we also call as a strategic halt. You can take it. You can see I have done a colpotomy, and inside the colpotomy I can see the cervical part of the fibroid, and we are expecting in the post-op period the patient will have some discharge PV, as the edematous vaginal wall and the fornices will discharge a bit, and there you can see such a large fibroid inside the upper part of vagina. So the colpotomy continues. I use only bipolar shearers for doing the complete colpotomy, else you can even use a monopolar scissors or cold scissors, or even the blade of ultrasonic scalpel also over here. So going step by step. If you are a beginner, please take a good gynecologist or a surgeon who is expert in these surgeries with you. as doing it alone is maybe a bit tricky, not difficult, you can say a bit tricky. And try to keep the anesthetist with you, as the anesthetist has a very good observational power, as he has seen many gynecologists and surgeons operating. And please ask him or her how you are operating, or if at all any steps you need to change or upgrade or alter, as they have lots of idea, because obviously they have seen lots of surgeons operating, lots of gynecologists operating. So the surgery is almost complete. Look, at that point of time the bipolar was not cutting well, so I am using cold scissors for cutting, as cold scissors are also very good enough because it's very dense. And you can see there the upper part of vagina is folded inside. And look how symptomatic the lady would have been. So continuing with the bipolar shearer. You can see the part of the cup, the Marvas manipulator cup inside, and I'm almost there. The vaginal wall is so thickened up, it's around 1 centimeter thick, and in the post-op periods obviously she'll have quite a bit of discharge for 3 to 4 weeks till the whole of the edema settles down. So the surgery is almost complete. You can see how thick the anterior fornix is. Don't worry about the bladder, that's far away. You need not keep the catheter for long in her case. So do like and subscribe the channel, and please give some comments on it as to if you have any ideas and what should have been done, or if you want to learn such surgeries, please comment and do like and subscribe the channel. You can come to Chandigarh. I do freelancing around Chandigarh and in Himachal Pradesh. We generally do around 20 to 25 total laparoscopic hysterectomies in a month on an average, and around 100 to 150 laparoscopic surgeries per month. So observing us will be a good thing, as observation is the most important part of learning laparoscopic surgery. There you can see the Marvas manipulator was there, and the uterus has been taken out. Now just the thing is, the assistant on the lower side will pull the uterus out after holding the cervix, or you can say the pedunculated fibroid. Bit of manipulation over there. You can see how big the Foley's bulb is looking, with only 5 ml of distilled water in it. So the surgery is complete. Now only remaining thing is taking out both of the fallopian tubes and suturing the vault. Both the ovaries look very healthy. Here I am using normal temperature, normal saline with a 5 mm port for cleaning. And there you can see very bulky vagina. We will not do anything about it. We will just suture it, and in the post-operative the NSAIDs will take down the edema once the specimen has been removed, and this edema will settle by itself. Nothing much to be done. Let the body take control of it. A short burst at the edematous site before the suturing, and there you can see that was the uterine. A bit of heating of the uterine again, so that it should not bleed, as differentiating the uterine clearly was not possible when you are doing the colpotomy or taking the uterines. You can see how edematous the vaginal wall is at the level of anterior fornix. Now the salpingectomy is bilateral with again short burst of currents, as the ovaries should not get devascularized, to stay away from the IP ligament. Similarly on the other side, the bipolar shearer wattage is on bipolar FS mode, and it's at 25 watts of energy. There, those are out. The only thing remaining is now suturing. Suturing is an integral part of laparoscopic surgery. As the famous laparoscopic surgeons say, there is no future without suture. Cleaning a bit, looking for hemostasis. If your surgery is going step by step, hemostasis issues is never a problem in laparoscopic surgeries. And the blood loss in laparoscopic surgery is a very bare minimum, maybe 5 or 10 ml. So please do start doing total laparoscopic hysterectomies and laparoscopic myomectomies. Do not shy out with laparoscopy, and I'll help you to gain your confidence in laparoscopic surgery. The more you observe is the more you learn. And that's number 1 vicryl that will be used in a continuous fashion to suture it. It's a regular suturing, and from the ipsilateral port, when you start suturing from the ipsilateral port, you will become an expert, and the shoulders will also not get tired. I always repeat that ipsilateral 3-port total laparoscopic hysterectomy is a very good surgery, and it is very easy. Don't use contralateral port, and especially if your height is less and you have a very low and not that low laparoscopic table, operating from opposite hand is very difficult. Now I've been doing all the surgeries in 3-port. I seem to be obsessed with 3 ports, but that's not so. Everything can be done with 3 ports. That's the uterosacrals that I'm taking with it, as the edema has altered the anatomy a bit. Quite bulky structures. A bit of jagged, or you can say ragged tissues. This will come to normal after the edema settles in 2 weeks time, though she'll have a bit of spotting for a few days post-operatively. And as it was very edematous, the chances of this vault prolapsing is quite high, so we'll tack it beforehand only, as we do in cases of TLH. When we do in prolapse uterus cases, the stump of the round ligament will be used to hitch it, and so the chances of vault prolapse is 0. This vault will never prolapse, so no issues. The suturing here I am showing in 3x speed, as it's a regular suturing, nothing great. But the tacking part is important, as once the edema subsides and the vagina is very lax in this case, this will prolapse, and so avoiding the prolapse beforehand only. Laparoscopic hysterectomy in uterine prolapse, 4-degree prolapse with cystocele and rectocele, is managed very well laparoscopically, as if you pull the vault up with the stump of the round ligament, that's all that's required. You need not to cut the vaginal mucosa to repair the cystocele. And once you see it, how it is done, once you see the post-op recovery of the patient in the case of grade 4 prolapse uterus done laparoscopically, then only you will believe it. Else you will never believe, and you will feel that a vaginal hysterectomy with cystocele repair is better. So please take my words. A regular total laparoscopic hysterectomy with suspension of the vault with the stump of the round ligaments is the best way. No need to cut the vaginal mucosa. The patient will heal very fast. So I have tacked the both sides of the round ligaments with the vault. That's all that's required, and the surgery is almost complete. No issues with that, a bit of blood coming in, because the sutures will take care. Suturing is in 3x speed, so don't worry that I'm doing it very fast. It's a very regular, slow and steady suturing that's going on. You can see how the vault is pulled up, and post-op pain or discomfort, there's nothing like that, as some would say. It's not like that. And if you have such a patient, I'll again say, do not start the patient on mifepristone, as it has softened everything. Just go ahead and do the surgery. Please improve your skills and go ahead and do the surgery. Do not let the patient suffer. And if you are not able to do it, please come and join me and learn laparoscopic hysterectomy. That's a very good procedure for the ladies these days. The recovery will be in 1 day. Only 3 small holes. So look how nicely the surgery has got completed. The edematous vaginal ends. This will settle in 3-4 weeks with a bit of spotting in the post-op period. You can see a bit of calcification on the appendices epiploicae. So that's the wash, and you can see that's the calcified fat on the appendices epiploicae. Nothing to worry, you can leave it alone. So the surgery is complete, and finally we'll put some of the omentum in the pelvis, as this will take care of any injuries, if at all, that must have happened. The vascular bleeding and even the VVF chances are put to 0 with this, as spontaneously it will never come down, as sigmoid will cover the suture line. So please do like and subscribe the channel and follow me for more such videos, and do comment if anything you like to learn from me. I hope you will come up in the discussion part in this channel, and waiting for you to join us as an observer with me in the favor of the ladies. So no abdomen should be opened up for any pathology of the pelvis. Please do put in a laparoscope and do it laparoscopically, and if you are not able to do it, I am here to teach you. Thank you guys. Okay, bye. Happy operating.